allowed to host Fertility Week. We are a registered charity that has been providing information, support and advocacy to New Zealanders with fertility issues for over 25 years. We provide information through our website, printed leaflets available at New Zealand Fertility Clinic. Provide support, which is largely through a network of wonderful volunteers in different locations around the country who run regular groups and advocacy to represent the voice of New Zealanders with fertility issues like the government. Now I'd like to hand on to Dr. Guy, who is a fertility specialist and medical director of Fertility Treatment in Auckland. Thank you very much, Goody. If anyone has questions, please type them into the box as Dr. Goody said, and he'll probably out time or wait till the end of the presentation. Okay, thank you.
Oh, thanks. Kia ora, everybody. And thanks, Nicola, to Fertility New Zealand for this opportunity to give an overview of fertility treatment in New Zealand. I'm going to talk also about public funding and some of the parameters around that. And then, probably after about a quarter of an hour presentation, throw it open to any questions. It doesn't have to be particularly to do with treatment or public funding access. I'm happy to talk about anything related to reproductive health. In terms of fertility, it's an incredibly important part of people's lives. People often will plan to have children, to start a family, and then it can be very stressful when you don't get pregnant according to that plan. And I think it's really important that at a relatively young age, men and women are given the information about planning for that fertility. There was an article in the Herald earlier this year saying that if you plan to have 3 children, you should really start by the age of 26 or 27 to give yourself a really decent length of time. And the message behind that is that age, particularly for women, is incredibly important. The last 30 years, it's crept up now to about an average age of 30 for having first baby in New Zealand. And that's fine for a lot of people, but remember that your egg count can start to decline from about 27, 28. And so for about 10% of women, leaving it to 30 can be too late. There's a very clever blood test called AMH, which you can do at 26, 27, 28, to at least benchmark where things are at. An increasing number of people are choosing to do that so they can plan accordingly. Really important to be aware of some of the lifestyle issues around fertility. Weight, being underweight or overweight's had quite a lot of publicity. Also stress and alcohol, obviously the importance of not smoking. We used to say that women and couples should try to conceive for about 12 months before seeking help, but in fact it's very reasonable to do that younger, at 6 months, if age is a concern. And some of the tests are very simple to do, particularly, for instance, a sperm test. And so it's not necessary to wait if you're worried about it. You can be referred by your GP through for a public consultation. The rules vary a little bit depending on which part of New Zealand you live in, but certainly here in Auckland, so long as the woman is under the age of 40, it doesn't matter what your BMI is or whether you're a smoker, you can come for a consultation. The limit then will be on whether you can access treatment or not, and I will talk about that a little bit later because that is a separate set of rules. In terms of fertility options, once it's been identified that there is a problem, obviously waiting is an option for some people, and that might be because they have an aversion to having some treatment. It might be because they're not eligible for publicly funded treatment and can't afford private treatment if that's indicated. And many couples will fall pregnant eventually, but just be aware that obviously age can be a limiting factor. And we generally say when we assess someone, you know, how long have they been trying and how long do they have left of reasonable fertility? Probably the commonest, simplest treatment that we offer is where we identify that ovulation is a problem, and that may be related to polycystic ovary, for instance. And so if someone's having regular periods, that's a usual indication of ovulation. We do a blood test in the second half of the cycle to confirm it. But if we have concerns around ovulation, along with lifestyle modifications like losing weight, letrozole and clomiphene are two of the most commonly used drugs. Letrozole's now used way more commonly in New Zealand than clomiphene as the first line, because it's simple to take like clomiphene, but probably has a better chance of getting pregnant, and most importantly has a much lower chance of twins. And it's really important in fertility treatment, is minimising the risk of twins. There's been publicity about intrauterine insemination a few months ago because of a New Zealand study looking at clomiphene with IUI. Clearly the tubes have to be normal to do intrauterine insemination, so we will usually recommend that the tubes are flushed in some way, either through a laparoscopy or through a X-ray to check that the tubes are patent. Sometimes that on its own can improve the chance of getting pregnant. And again, there's been quite a lot of publicity recently about Lipiodol, which is a poppy seed oil flush that can be used through the tubes and can, independently of any other treatment, improve a woman's chances of conceiving naturally. So an increasing number of people are doing that. There's very limited public funding for that option. Intrauterine insemination is publicly funded if you meet the criteria, which I'll talk about in a minute, and a package of 4 intrauterine insemination cycles is what's available, equivalent to 1 IVF cycle. IVF is probably the treatment that gets the most publicity. As you may know, it's been around since the late 1970s, and it's become a lot simpler and less stressful in the last decade, mainly because we've managed to make it more user-friendly through shorter injection time, simpler methods for harvesting the eggs that are less painful, and the success rates have significantly improved compared to 10 or 15 years ago. So again, a typical IVF cycle is now shortened down to about 2 weeks, and a lot of people will continue to work during that time and just take the time off, maybe for the egg pickup and the embryo transfer. And IVF probably is used in about 1/4 of couples or patients that approach us for help. ICSI is where we add a single sperm into the egg, so that's IVF with ICSI, and we do that about half the time. So we do it either where there's been a very long length of unexplained infertility, or we'll do it where there's clearly a sperm defect identified. It's important if a man is doing IVF with or without ICSI, that for 2 or 3 months he's taking antioxidants. There's now good evidence that antioxidants will improve the chances of the treatment working, and that's through making the sperm more genetically healthy. There are many preparations on the market that combine all of the good things into one preparation, and that's a daily preparation for about 3 months prior to the treatment. You'll also probably be aware that the other big change with IVF in the last 10 years in New Zealand is a huge reduction in the twin rate. So we now largely just put a single embryo back. And so what that's also pushed is our ability to identify the best embryo to put back. And genetic screening of embryos is a pretty big development in that. So again, we're trying to reduce the risk of miscarriage and trying to improve the chance of getting pregnant more quickly by being able to biopsy and genetically test an embryo. It can't be put back immediately. We have to freeze it and then wait for the result to come back, and then it's put back as a thawed embryo transfer a month or 2 later. In terms of public funding, about half of IVF in New Zealand is publicly funded, and about half is paid for by patients. And unfortunately, insurance, other than the police health plan, doesn't cover insurance. The public funding has pretty strict rules around it, and most parts of New Zealand, apart from Dunedin, have about a 15 to 18 month wait, unfortunately, now, once you are eligible. In terms of the rules, a woman must be under 40 at the time that she's scored as eligible. Essentially, you can get enough points to straight away go on the waiting list if you have a serious problem identified. So that might be severe endometriosis, blocked tubes, a significant sperm problem. If you've got unexplained infertility, you unfortunately have to try for 45 years before getting enough points. The woman's BMI must be less than 32, and the woman must be a non-smoker. So it can seem quite complicated, the system for whether you're eligible or not for treatment, but that can be determined at an initial consultation with a fertility specialist, and you'll be told either that you're eligible straight away, in which case you'll have a 12 to 15 month wait, unfortunately, or you're not eligible, but you may do so with the passage of time. Many of the clinics offer publicly funded intrauterine insemination with a shorter waiting list rather than having to wait 12 to 18 months for IVF. And you can mix and match a bit, so you get two packages of care in the public system. Some couples will try a package of IUI first and then use their second package for IVF if the IUI is not successful. As I touched on earlier, age is a really important prognostic factor in success rates. We know that around the age of 35, the chances of success with treatment just start to drop off slowly and increasing after 40. We know that the risk of having embryos and babies with unbalanced chromosomes starts to go up more significantly at 35. And so we're finding an increasing number of patients around 35 and more want to do genetic screening of embryos, for instance. IVF partly is about the cumulative pregnancy rate, and so that's putting one embryo back and then another. And we're actually able to get pretty reasonable live birth rates cumulatively for patients under the age of 40. It's a real problem still that many women don't realise that IVF is not very successful once you get to 44 or 45. And most people who have babies beyond that age are using donor egg. The average age in New Zealand for women having publicly funded treatment, for instance, has now crept up to about 36 and a half. In terms of treatment success, IUI, if it's well selected, if the sperm is good quality, the tubes have been proven to be patent and the woman's under 40, we would guesstimate that about a third of couples who try IUI will get pregnant, maybe 35%. And we've roughly equated that to about the success rate with an IVF cycle, although IVF in a younger woman is probably slightly better than that, particularly cumulatively. And one of the secrets to success with IVF is trying to get a spare embryo or two for freezing. We're now finding that the success rates with frozen embryos are in fact better with fresh, although we're not actually comparing apples with apples exactly, so you need to be careful in that analysis. But we're also increasingly not putting an embryo back immediately if there's a greater number of eggs than we expected obtained, if we're worried about managing hyperstimulation. With IVF with ICSI, the success rates are really the same as whether conventional IVF is used or not. But again, we have some little tricks for trying to optimize the sperm that we select for IVF. And there are techniques such as PICSI and IMSI, which clinics use. IMSI is selecting a sperm under very high magnification. PICSI is getting the sperm to swim through a natural barrier and see which binds the best. And there's evidence that that's the most genetically healthy sperm. So there are lots of little things that can be done. We here at RepPromed use EmbryoGen in specific examples of previous miscarriage or previous poor embryo quality. It's a special culture media that will hopefully give better blastocyst development. In terms of is IVF safe, it is overall a very safe treatment. With the modern drugs that we've now got, we've hugely reduced the risk of ovarian hyperstimulation syndrome. We now freeze all the embryos and don't put one back in about 30 to 40% of cycles. And with AMH blood tests, which I mentioned before, we're much, much better than 10 years ago at predicting who's likely to be at risk of hyperstimulation syndrome. and take strategies to minimize that. There's no strong evidence that abnormalities are significantly more common because you've done IVF. And as I mentioned before, genetic screening offers a real chance to reduce the risk of miscarriage with treatment. Previous speakers have touched on the emotional impact of treatment, and there's lots of different strategies for managing that, including counselling, support groups, acupuncture, and exercise. Thank you very much. That's just an overview of some of the current issues, and I'm very happy to answer any questions. There's a first question: is there a daily antioxidant that you would recommend taking to improve sperm before treatment? There are about 4 preparations on the market in New Zealand that include all of the things that seem to be sensible. There's no strong evidence that one is better than the other. Probably Vitamins and Menavit have the highest profile in New Zealand, and they contain all the things like zinc, selenium, garlic, vitamins that have been proven to have an antioxidant effect in men. And it was a pretty big meta-analysis a few years ago that showed that it's definitely sensible for men who are undergoing IUI or IVF treatment to be taking an antioxidant. There's also some very recent evidence suggesting that there's some benefit, although it's probably less, for women to consider taking antioxidants as well. Next question is regarding public funding. Can allowances be made for having a high BMI due to having higher muscle mass and or bone density than average? So the answer to that is that currently there isn't. Clinics do have the ability to use what is called clinical override and to allow people access who don't meet the criteria, but it's not used for overriding BMI generally. There's certainly very good evidence that BMI isn't a very good marker of obesity, particularly in Māori and Pacific Islanders. At the moment, however, that criteria of 32 looks like it's going to stay in place. Next question is just saying that Katie's had 2 laparoscopies for endometriosis, and on the second, the tubes were dye tested, and currently waiting for IVF as the treatment plan through the publicly funded system. Would I recommend trying clomiphene while waiting? I think that would be a reasonable thing to do. The evidence that clomiphene in someone who's already ovulating is going to be significantly helpful is pretty weak. Having said that, I think there is some limited evidence that it might be helpful. You can be reasonably confident that certainly for the first few months that you take clomiphene, you're more likely than not to ovulate regularly. And some women, as they get into their late 30s and early 40s, will find that they skip 2 or 3 months in a year without ovulating normally. Clomiphene does have quite a long half-life, and so it can build up in your system. And we find that some women, fairly small number, but some women it can affect the lining, and that make that thinner, affect the cervical mucus also. So on balance, I think if you're concerned about age, you have to wait for public funded IVF and there's a reasonable wait. I think taking some clomiphene would be reasonable so long as you understand the limitations. The risk of a twin pregnancy if you're over 35 is probably very low at about 3 or 4%, but we tend to monitor for the first cycle to check the response. Lydia's asking, what are my thoughts about GCSF to thicken the lining? I couldn't have a fresh transfer due to a thin lining, and I've now had 2 FETs cancelled, 1 natural and 1 manufactured. Cancelled for the same reason. A hysteroscopy didn't show anything. Is there anything else you'd recommend? Thank you. So GCSF is colony stimulating factor. It's a naturally occurring substance that in some small studies can help the cells of the endometrium thicken up. One of the problems is that the case reports of it being used are pretty small. So one recent study looked at 4 or 5 women only. I've used it recently in 2 patients, and one I think it definitely made a difference, and the other not. It's very simple to use. It's just put into the intrauterine cavity every 2 or 3 days as a small intrauterine insemination. It's not inexpensive. It's just under $1,000, I think, for up to it gives you enough for about 4 different inseminations over a week or 2. So the answer is that it might be helpful because we don't have a lot of other things currently if the usual things haven't worked, but the evidence is pretty limited. Erin's asking, do initial fertility consultations typically include hormone testing? So this question, I guess, is around what would we normally check in an initial fertility consultation. So many of us will, it's not a hormone, but many of us will check a hemoglobin A1C, which is a screening test for diabetes. We will generally request an FSH, which is a brain hormone done during the period. And that's a less accurate measure of ovarian reserve than AMH. AMH, we think, is much more sensitive. But again, it can help interpret AMH a little bit if we look to see whether the FSH is normal or not. And we will often, usually, do a progesterone blood test in the second half of the cycle to see if ovulation is occurring normally. Thyroid function testing won't routinely be done, but will be if we think there's an ovulation issue, and we would do more specialized hormone testing like prolactin if we thought that was an ovulation issue. We will do testosterone probably only if we suspect polycystic ovary syndrome. Liz is asking, hi, have you had any experience with women post-radical trachelectomy and their treatment options? Thanks. So this is radical surgery for cervical cancer. I've had some experience with that. So usually, obviously, the ovaries will be preserved. And quite often, options such as surrogacy will need to be considered. So there are quite a lot of options. The main thing is that the ovaries are preserved and protected from if adjuvant radiotherapy is required. And also that brings up the whole issue of that patient may have done fertility preservation treatment. So that's freezing eggs or freezing embryos prior to the surgery. Arts is asking, if you've not started ovulating after being on Depo-Provera, can IVF be started before ovulation starts? So the answer to that is yes. We don't need you to be ovulating or have ovulated before starting IVF, but we would always do some baseline blood tests first to make sure, first of all, that the patient's not pregnant, also to check that baseline hormones are normal. But yes, you could do IVF having been on Depo-Provera. You'd always give it about a 4 to 6 month gap between your last injection and starting IVF. Mr. and Mrs. Snott are asking, is the clinical override on funding criteria available where, for example, the 2 children from a previous relationship are twins? So one successful pregnancy, but because they live with one parent, say 70% of the time, that parent and the new partner who have no children are eligible for funding. So no, I'm not aware that clinical override is used in that scenario. What this question is referring to is that the access criteria and the scoring for access for treatment is reasonably complicated around previous children and existing families. So any couple who have 2 biological children to that relationship can't access publicly funded treatment under any circumstances, but at the moment, if you have 1, you can. When the scoring is initially done, you get maximum points if you have no children at all, but that doesn't mean you can't qualify if you have other points, say from how long you've been trying or what's wrong with you. And then you get slightly fewer points if you've either got a child already in the relationship or you have a child from a previous relationship. And the previous child is defined as living with you for, or the child is defined as living with you for 50% or more of the time. Art's saying, sorry, I forgot to ask, can your AMH levels show as lower if you have the depot in your system? The answer to this is that it may. We know that the oral contraceptive pill definitely can lower your AMH level. And so we generally recommend that if your AMH is concerning on the pill, it's sensible to stop the pill and then probably wait 2 to 3 months before rechecking it. We used to think that AMH levels were pretty unchanging, but in fact there's new evidence that in about 10 to 15% of women, an AMH level can change not insignificantly either on a month-to-month or over a longer period of time. So I always recommend that if an AMH levels are suppressed and a real concern, it can be worth repeating at an interval, and definitely worth repeating, say, a year after it was previously done if fertility is still a concern, to see whether it's declining significantly. What are your thoughts about the PIP test, and is it worth doing before IVF? So this will be referring, I think, to Papel testing, and this is the so-called endometrial scratch. And although it's fairly simple to do, you come in the second half of the cycle before the month that you plan to do IVF, and a little catheter is placed up through the cervix. The concept behind it is that you're scratching one part of the lining, which causes the lining to produce growth factors that might help an embryo grow. The problem is that really big studies have both shown some evidence in favour and others have shown no benefit at all. And I think currently we're not in a position to say that it's definitely of value. One of the problems, though, is that if you are experiencing recurrent implantation failure, so you've had more than, say, 4 good quality embryos back and you haven't achieved an ongoing pregnancy, what options have you got? And the answer is that there are several, but not very many of them are particularly evidence-based. It might be intralipid, it might be trying Lepidol, it might be trying Papel endometrial sampling. Rachel and Pete have asked, would a letrozole IVF cycle be an option for a low AMH? The answer is that it might be. So when your AMH is very low, you traditionally don't respond very well to the FSH drugs, the FSH injections that we traditionally use. And we can find occasionally that, in fact, people will respond much better, still only getting 2 or 3 or 4 eggs, where letrozole is added in. We also use letrozole quite commonly. This is, remember, the drug that we use just to get couples, a woman who are not ovulating with polycystic ovary ovulating. We also use letrozole in fertility preservation cycles, say for breast cancer, where we want to on purpose keep the estrogen levels down, which is what the letrozole does, while still being able to do an IVF cycle. Letrozole is also very cheap, and don't forget the very early days of IVF, we only got 2 or 3 eggs because we only had drugs like clomiphene available. So mini stimulation, sort of mini IVF, is becoming increasingly popular as an option where there's low ovarian reserve. Sheena's asking, I'm 32 with polycystic ovary. What would be the best treatment option and what are the chances of getting pregnant with letrozole? So polycystic ovary is a common condition. 20% of women have polycystic appearance on ultrasound. And we call it the syndrome when it has a manifestation such as an irregular period, irregular ovulation, perhaps increased body hair. And there are several treatment options for it. So if the weight is an issue, if a woman's overweight and age allows it, we will recommend weight modification, because often just 2 or 3 kilos in weight can definitely change ovulation. Metformin is a diabetes tablet that is also quite effective in polycystic ovary, probably not on its own, but in conjunction with letrozole as the first line. I've given it on its own to several women who have polycystic ovary, maybe having no periods at all, and who have been really wanting to avoid twins, even though the risk with letrozole is very low. And I've had some success with metformin just on its own. We also use metformin in IVF where polycystic ovary has been diagnosed. There's some evidence it reduces the risk of hyperstimulation syndrome, maybe reduces the risk of miscarriage. So metformin and letrozole is probably the way to go, and it's really simple to take, which is fantastic. So it's taken for 5 days, starting on the second day of the period. We tend to use a completely standard dose of 2 tablets a day. That seems to be the dose that gets most people ovulating. Very occasionally go to 3 tablets a day, and it's usually very, very effective. Arts has asked, is ICSI often used when using donor sperm? Some clinics always use microinjection or ICSI when donor sperm's being used, and that's because of wanting to really try and optimize fertilization and trying to minimize the risk of poor fertilization. Having said that, if the sperm has been of good quality when frozen, a trial thaw is always done to see that the motility's okay. It's perfectly reasonable to not routinely do ICSI with donor sperm if it's of good quality. ICSI comes at a cost, so if you're paying for it privately, it's about $2,000. And so if it's not absolutely necessary to do it, it's perfectly reasonable not to. Tashi said, hi, if I don't have enough points because of BMI, would I be able to try Clomid or letrozole while I'm losing weight? Or do I have to get my BMI down first? So that's a really good question. The answer is that there are no strict rules around whether you can or can't take it. It more depends on your doctor's viewpoint. And it raises the question of, what is a BMI that's reasonable to assist people getting pregnant. In our clinic, we'll always recommend weight loss first, but sometimes it's not realistic if age, for instance, is becoming a real issue. And we've certainly given letrozole and or clomiphene to women with a BMI between 35 and 40. If there's no other comorbidities, we're aware of the increased risk of gestational diabetes, for instance, which is developing diabetes in pregnancy. And it's trying to find a balance really between what's reasonable, what's moderately safe, involving patients in the conversation as opposed to just a point blank no. There are increased risks both in pregnancy and with birth with an increased BMI, but again you can have exactly those same arguments. Is it reasonable to assist women 45, 47, 50 to have a baby using donor egg? And although the risk is increased, the risk is still relatively low. And so again, it's a conversation that we would have with individual patients. We don't try and put a blanket absolute rule. All right, I think that's about the end of the questions by the looks of it.
Yes, I think that is it for questions. So unless anybody has, there's one more. No, that's just a thank you. So thank you everybody for coming tonight, and especially thank you to Dr. Guy Goodnex from RecPromed for sharing your time and expertise with us tonight.
Pleasure, thank you.
Okay. Good night. Thank you.
Ko Marie.